Welcome to today's webinar, everyone, at the Follicular Lymphoma Foundation on Relapsed FL, the Essential Insights. I'm Nick, I'm the Research Manager at the FLF, and we're really excited to see so many of you here today. Thanks for joining us. The webinar is part of a series, and each webinar will take place every other month on important FL topics. So please do register your interest to stay updated. I'll post a link in the chat after, and all our previous webinars can be found on our website under your support hub. So just some housekeeping before we get started. Today's webinar is being recorded and we plan to upload it onto our website where only the speakers will be visible. I love that so many people are already chatting away in the chat box, so please do continue to introduce yourselves and also use the Q&A box, and we'll answer questions throughout today's session, and we'll also respond to the questions that have been answered during registration. And if we don't get to your questions today, then we'll come back to them via various other communications after the webinar. There is the option to ask your questions anonymously, so please do feel free to do so. So yeah, enjoy the webinar, everyone, and over to you, Mitch. Thanks.
Thanks, Nick, and I do appreciate everyone being here and joining us. We are still in Blood Cancer Awareness Month, so we're I like to think of this as part of that awareness, and our job at the FLF is to raise awareness of follicular lymphoma in particular and support research efforts in that regard. We'll have a series of sections as we go through. There's a bit of flexibility, and I can see already that there's absolutely no way we'll be able to answer all your questions. But as Nick said, we will have subsequent follow-ups, either frequently asked questions and other videos and media to address them, because this is obviously the meat of follicular lymphoma, and there's so much to talk about. And I'm really honored today to have with us two special participants. Andrew McCaslin is a patient, and he'll tell you a little bit about his experience, and we'll drill down on how that might mesh with yours. And also Philippe Armand, and I'll let him introduce himself in a second. As I continue to talk, there is a poll up. We'll have a couple of polls during the meeting. This one is, what is your current FL status? And there should be a drop down for answers. I'm just looking at mine, but yes, so I can't, but yeah, so while we're talking, please do vote and tell us where you are in your course, and that helps us understand how to address questions in the future. So let me start just by introducing Dr. Armand. As I mentioned, he's the head of the lymphoma section or division at Dana-Farber Cancer Center, which is a well-regarded cancer center, one of the comprehensive cancer centers in the U.S. That's in Boston. And they have a great lymphoma program, and I'm happy to have him with us. Philippe, you want to say a word or two about your background? And
sure. First, thank you for inviting me to be here. And it's very nice to be here with you and Andrew. I'm French originally, came to the US for college many moons ago, and I did my medical and graduate training at UCSF in San Francisco, and then I came to Boston for residency and fellowship at Dana-Farber. I've been at Dana-Farber on staff for about 17 years now. And as you said, I run the lymphoma division here, and we have a super group of lymphoma physicians and researchers, and we're very excited and we're very grateful for the support of the FLF in our work.
Great, and Philippe's modest, but he has a great program up there. And Andrew, well, before I introduce you, because then I want to go from what you're saying into the first question. I do want to see if we can look at poll results. And while we're waiting for that to come up, I understand that just looking at the chat and knowing that there's people on the call who have various bits of knowledge of follicular lymphoma. Some of you know very detailed every single thing, and others are fairly new to follicular lymphoma. Because you're here, I expect that you have some knowledge, and we can't go to what is follicular lymphoma, et cetera. There are sections on our website for that, but we're going to presume some knowledge of at least some of the treatments and of the disease. But I'm sorry if there's anything that's totally confusing you and lost, put it in the chat and we'll try to answer it now or later. So today we're focused on what is relapsed follicular lymphoma. We understand that there is a risk of transformation. There's questions a lot already on early progression, so-called progression of disease in the first 2 years, or POD24. We'll cover a little bit about POD24. Transformation is a separate issue, and we will have subsequent seminars or webinars on that. So we're not going to talk too much about that. I just want to let you know about that in the start. And just for the status, I'm seeing that a little over half the people on the call are in remission, and 12% are experiencing a relapse, 11% are on treatment, and 5% are newly diagnosed. So hopefully won't face this question for a long time, but certainly reasonable to learn more about it. But I do think that almost 60% are in remission, and they're probably thinking about, gee, what do I do if and when it comes back? How do I know? And we're going to talk about some of those questions. Somebody says I'm frozen. Hopefully you can hear me. Okay. Anyway, so that's the poll. So now I want to move to Andrew, and I really appreciate your being here. And you know, I think you've been through a relapse, and maybe tell us a little bit about how that came about, a little bit about your story and your experience and how you felt when you're in remission and then when it relapsed, and get us started that way. Take it away.
Yeah, so I was initially diagnosed at 25 years old about 3 years ago. I was diagnosed at stage 4, and I started treatment straight away. I had 6 months of rituximab and bendamustine, and I achieved remission, no evidence of disease. And then after about a year, I started experiencing one of my typical symptoms was discomfort in my sort of bowel area. So I had quite an intense week of those symptoms, which triggered me to get in contact with the hospital again and mention the symptoms. And I had a scan at this point which showed that my FL had returned after around a year of remission. And this was around 2 years ago now. And I've actually been on watch and wait ever since this relapse. And initially, because I had relapsed within the first 2 years, the doctors thought that I would need treatment within 6 months. But each sort of 6 month scan I've had has shown some progression, but it's fairly stable, and my symptoms are quite under control at the moment. So I'm very much seeing how long I can last before needing treatment again.
Great, yeah. So there's so much there in that story that I'm listening that address some of the questions people have. So one of the things, of course, is how do you know it comes back, and what's the chances it's going to come back is a common question. And how do I know, Philippe? When a patient's sitting there, they finish their bendamustine rituximab for 6 months, and their CAT scan looks good, and they're sitting there in your office a couple months later. What do you tell them about what's the chance it's coming back? What can you expect in terms of time? And they're going to ask you, how do I know when it's back? So what do you tell your patient sitting across from you then?
So as you said, there are a lot of questions contained in this. The first one about the probability of relapse, I think what you hear and read is that follicular lymphoma is an incurable disease with standard treatment that includes chemotherapy. So the textbook answer is we expect everyone to relapse. It's not actually true for me. I think if you look at basically any treatment for follicular lymphoma, there's always a tail on the curve. So there always seems to be a proportion of patients who never relapse. And that's true whatever you use, even if you just use Rituxan alone, and certainly if you use Rituxan bendamustine. It's hard to know what that percentage is in the very long term. So because patients may be lost to follow-up, etc., maybe elderly patients. But I think with a regimen like Arbenda, there may be maybe a quarter, a third, maybe a little more of patients who may never relapse. So that's the first part. Now, of course, in Andrew's case, that part's already unfortunately been passed because you already have a relapse. The second question is, how do you know, or how do you look for it? And again, there's variability in practice. I personally don't do any scans or any routine scans after the post-treatment one. So someone, as you said, Mitch, someone is in complete remission by PET, I wouldn't scan them again. And I think there's a question in the chat about it, but anytime we scan patients, we give radiation exposure, which we know is harmful. And there's no evidence whatsoever in this disease that catching it early before the appearance of symptoms has any benefit. And in fact, if you catch it and someone is asymptomatic, as I guess is now the case, I hope, for Andrew, watchful waiting is a reasonable option. So there really is, in my opinion, no need for scans. And the relapse is often symptoms which may be similar to the starting symptoms, as it sounds like they were in your case, Andrew, or they may be different. They may be palpable lymph nodes. They may be pain, unexplained pain, like abdominal pain, etc. They may be problem with the blood counts, like low red count, low platelet count, or they may be these constitutional symptoms like fevers, drenching sweats, weight loss, fatigue, that don't necessarily mean the lymphoma is back, but that at least clue us in that at that point it's probably useful to do a scan and look further.
Yeah, I think I would agree with that. That scans, we don't treat if the nodes get a little bit bigger and you're feeling fine. We don't treat. So why would you do the scan all the time? And you have anxiety. So, and so, Andrew, when it came back, you fell into this early progression, and everyone's concerned. I think one of the keys is that POD24. That's a marker of patients who may need treatment sooner, but not everyone, and you're the model case for that. So, we tend to treat those early relapses more intensively, and I think people talk to you about fairly intensive treatments, and they weren't wrong, but now you've proven that, okay, your disease came back early, but it's behaving indolently, and another common question is watch and wait okay when you relapse? And the answer is absolutely. Many of the same criteria. So tell us a little bit about, what because you relapsed early, a little bit about what they first recommended. I understand it was different hospitals, but what they recommended, which was not, it wasn't they were wrong. The new doctors later then had the ability to say, hey, you've been stable for a while, we can watch. But what did they talk to you about when it first came back early?
So initially, they mentioned the relapse within the 2 years, as you mentioned, and my wife Leah had done a lot of reading about the topic, and that was a big concern for us, and the risk of transformation. And I think their idea was that it was gonna, because it had come back so quickly, it would progress and grow quite quickly as well. So they were expecting the treatment within the first 6 months to be probably RCHOP, or a combination with some sort of stem cell transplant. So I actually had a stem cell harvest in preparation to potentially have that treatment, which is, as you say, quite intensive, where with the transplant you would have to be in hospital for potentially weeks, just because your immune system is sort of ripped back down to its bare bones. So initially it was quite scary, because they were talking about these harsh treatments, and they said it was going to happen quite quickly. So we were really preparing ourselves for that situation and just trying to tackle that. But as you've sort of alluded to, we changed hospitals after a period of time, and in that time it hadn't grown too much. It had stabilized, and the new hospital suggested a range of treatments were now an option for my second line, which I'm still obviously waiting to have. So it's going to be quite dependent on where our lives are at and what suits the disease or my life at the time.
Right, I'm going to pick this up in a second, but there's a second poll up there. We're asking how familiar you are on a scale from 0 to 5 of, the concept of FL relapse. We're here to talk about relapsing FL, and, are you absolutely certain, you know, the audience, if you know everything about it, or you just want to know about treatment, or I've never heard of this and I just on the learning phase because I was just diagnosed. So, oh, that poll's already up. Okay, sorry, I guess that was there. So it's really a mix. I would say, you know, about a third of the patients feel that they're familiar, but you know, probably 10 to 20% are not familiar at all. So it's a mix, and that's good in terms of targeting where we're going here. So that's useful information. So Philippe, two questions here. One is, I don't want to spend too much time on the POD24 patients, but if Andrew's case had progressed like they expected, and in 3 months he was more symptomatic and things were growing, R-CHOP and stem cell transplant, is that still considered a common second line therapy for you? Do you thinking are CAR T in there? What's your thoughts on how you would treat those early progressors who require treatment?
So also not an easy question. And if I may ask, Andrew, if you don't mind, did you have a biopsy at relapse?
Yes, I did. I had a bone marrow biopsy.
Did they find the follicular lymphoma, or did you have a
No, that was clear.
But did you have a biopsy of the lymph nodes to prove
in initial diagnosis I did. That was one I had. It's quite a long story, but I had quite a long route to diagnosis, and sort of closer towards being diagnosed, I had lumps coming up in certain areas. I had a biopsy on one just under my collarbone initially, and they found that's how they realized it was follicular lymphoma. That they knew from a scan that it was some form of lymphoma, but that was how they narrowed down which
not
type.
not the second time around.
The second time around, there was no visible. I do have some visible lymph nodes now, but at the time it was just picked up on the scan. So there wasn't I actually had a bone marrow biopsy, sorry, before my stem cell transplant, not actually after relapse. So I just had a scan and that was it.
So
yeah, Philly, so I think you're driving at, should you have a relapse in early, to make sure that it's still follicular and hasn't transformed to something that requires more aggressive treatment?
Right. So this is, of course, it's delicate, right? I'm obviously not your physician. I don't know your scans, your case. So don't think of this as medical advice. But having said that, I think for me, one of the cornerstones of management of FL is always biopsy. And the reason is, as you alluded to, the POD24, at least I have come to think of it differently than it used to be. People used to think of it as a high-risk marker for FL. I think it's different. I think it is first a marker of transformation. So many patients who relapse early, especially after something like R-bendamustine, which is a powerful treatment, have transformed disease. And that's a different treatment, different path than relapsing with untransformed follicular lymphoma. So that, again, to me, in general, not in your case, but in general, a biopsy for a patient with early progression is absolutely critical. And then we can leave aside the issue of transformation because that's a different conversation and a different path. Without transformation, it's not so clear how bad POD24 is. And I think patients can be quite alarmed, but I don't think it makes actually that much difference, to be honest, especially with novel agents. It is a marker of chemo resistance, so chemo probably doesn't work that great. But now we have so many non-chemotherapy regimens, and in fact, we rarely use chemo twice anymore, at least in our practice. So I don't worry as much about POD24 once you've excluded transformation. And for the same reason, even though I used to use R-CHOP and autotransplant, I don't anymore for patients who don't have transformed disease. I don't think that's necessary. That's necessary if you have transformation. R-CHOP is a good chemo if you have transformation. If not, I'd say we'll save it for that in case it happens in the future and use agents that are at least as powerful, that are less toxic, and that don't require the same kind of, that don't entail the same levels of risk, et cetera, as R-CHOP and autotransplant. I hope that makes sense.
Yeah, and I think that's really an excellent point. This is a change in the field from POD24 is bad to POD24 is often a marker of transformation, early transformation, and otherwise may not be so bad. And so it's a subtle difference, but it is important. And I would echo the often, and Andrew went through some other procedures, and so there's differences in his case that changed that. But anyway, but I think that's good. But it's a good segue then to, okay, Philippe, you've alluded to all of the different treatments that aren't as intensive as R-CHOP and transplant, et cetera. And I think that's what a lot of people want to hear. What are those treatments? A lot of questions about lenalidomide, as well as, you know, bispecific antibodies and CAR T as T-cell engaging immunotherapy. So in a fairly concise form, can you sort of take away those things? If you've had immunotherapy up front and then you've relapsed and you haven't transformed, how do you balance those risks, benefits, or any like stand out as the best or save it for later kind of things? What's your approach to that?
So you're by now used to me saying, well, that's actually a challenging question. So
they're all challenging. That's why you're here.
I wish you just asked me an easy question, like yes, no question. I need one of those. So in general, the challenge, if we say the challenge is not really the POD24, the challenge is that currently there's actually only really one treatment that's approved for second-line treatment of FL, and that's lenalidomide, or R-squared, Rituxan lenalidomide. You can use chemotherapy too, but the only non-chemotherapy that's approved is R-squared. Everything else is approved in third line. That's CAR T, bispecific, zanubrutinib, tazemetostat, whatever you want. It's all third line and beyond. So if you practice according to FDA labels, which many of us try to, in second line, all you have is chemo or R-squared. So what about R-squared? Well, I don't think R-squared is a great treatment for follicular lymphoma. I think lenalidomide is a middling drug. The trial that got it approved was in a pretty favorable patient population. Most of them had only had one prior treatment. They were all Rituxan sensitive, so we know Rituxan is going to help in those patients. So it wasn't a high risk, not like patients in fifth line therapy who've gone through everything. And even then, despite all that, the outcomes weren't fantastic with R-squared. So I think it's good, not great. So you can use it as sort of a water treading regimen. You say, okay, we'll use R-squared now. Hopefully we get maybe a couple of years out of it, something like that. And then on the next relapse, we can use the rest of the arsenal, CAR T, bispecific, the stuff that is more exciting, I think. The challenge with that, and this is kind of a subtle point, I don't mean that arrogantly, but is that right now there are a lot of trials in follicular lymphoma, a lot of phase 3 studies that are looking at these new treatments like bispecific, et cetera, and that are using them earlier. So most of these trials are actually in second line and beyond. And basically all of them take a new drug and combine it with R-squared. And that's the experimental arm. So bispecific, tazemetostat, tafasitamab, whatever you want. So the general trial is new drug plus R-squared or new drug plus lenalidomide versus R-squared. And so I'm sure some of these studies are going to be positive. In fact, there was a press conference already about one of them being positive. I'm sure others will be, and I'm sure they will get FDA approved. So 5 years from now, I don't think people will use R-squared in second line. They'll use R-squared plus X. And if we use it now, today, in a patient like you, let's say, then let's say 2 years from now, let's say the disease comes back, R-squared plus X is going to be much less appealing. So there is now, today, I think, at least a theoretical reason to maybe try to back pocket R-squared and wait a few years for these trials to mature, because they're the next approved lines in second line, I think for most patients, they're going to be R-squared plus X or lenalidomide plus X. Did that make sense? I know it's, yeah.
Yeah, I think I like that. I think it highlights one of the things that if you don't need to get treated, if you can delay, new things are coming, new combinations, and also, or look for a clinical trial where there's a real combination. You know, a lot of our viewers are not in the US and are in places where some of these new treatments aren't even available, but they might be on a clinical trial. So I think that's another way of thinking about it. If I can get on a trial and get access to a drug that way.
Right.
Yeah.
So that's a key point, I think, when you have access. And there's now, so for example, here, this is Dana-Farber. We have a trial for patients with POD24 who are not transformed of CAR T versus standard like R squared. We're starting a trial of a bispecific combination with zanubrutinib in all patients, not just POD24, in second line and beyond. So within the context of clinical trials, as you say, there are usually more options and options to use novel therapies earlier than you can use them on label often. So I echo that strongly if that's an option.
Great. So Andrew, you got some ups and downs, in terms of, oh, I'm going to need treatment right away. They collected my stem cells, put them away. And then it's like, oh, now it's a couple of years and you're doing okay. You sort of tell the people on, how you feel, how that's affected your day-to-day life. And another common question, which I know you can't answer because I'm not only giving hard questions to Philippe, but what do you think you might have done to stabilize it? Did you do anything mentally, physically, things like that, where you think, oh, that's what really made it kind of settle down? I understand it's not scientific, but so how do you, just give us a little riff on those sorts of questions.
Yeah, so initially it was obviously very scary. You've only had a year out of treatment, so you think I'm going to have to go through this again. So it's quite daunting to start with, and it's constantly on your mind, and you're thinking, how long am I going to have? Because it feels very short term before you're back in treatment again. But so it's been sort of two sides to the story. So initially it was very like that, and then over time, as things have gone on, because we initially got told 6 months. So at that time I was engaged, and our wedding was planned for about 9 months in the future. So we looked forward and said that doesn't look possible. So this sort of started a chain of events where we sort of focused on just trying to do what we can and make the most of the time before the next treatment comes around. So we moved our wedding, managed to have that, and then the 6 months came and I was still okay. They gave me another scan to check if it was growing quickly or not. That showed it stabilized. So at that point, the perspective sort of changed from not you'll need treatment straight away, but we just need to monitor you now and see how you go. And from that point, I feel like the mindset, from my perspective, as you're sort of mentioning, is sort of a positive one to focus on each day in isolation and really try and make the most of the time that you have before you have to have treatment. And for me, being quite positive about it, I feel like has helped me focus on life and what I can control rather than things I can't. And that sort of carried on where me and my wife had our first child in this time as well. So we've made very, very positive choices, and I don't know if it has an impact on how my body reacts, but my symptoms have gone up and down. It's not just been a progressive decline. So something's working, and it's been great to just try and make the most of this time. And we're still nearly 2 years down the line from the relapse, so it's been really positive in the second half, I'd say.
What are your doctors, are they talking about any specific treatments if and when you need it, or are you just saying, I'll put that out of my mind, I'll worry about it when it comes, because there'll be different options? How are you approaching, or you or your doctors approaching that?
So we do ask a lot of questions. So we've talked about a few treatment options. One that Philippe has mentioned, the lalidomide and rituximab. So I think that's one of their favored ones. But there is quite a range. They've even mentioned a stem cell transplant from using someone else's stem cells, because I think they've looked at my age and seen that maybe I could handle something even harsher. So we've really tried to ask them to tackle my case, considering my age. I'm only 28 now, so there's quite a long time, hopefully in the future, to tackle any more relapses that come. So we've tried to have lots of discussions about what is the the right next step. But we have thrown a young baby into the mix, so lifestyle really does come into it quite a lot as well. So it's not just what's the best treatment to have next, also have to consider how it affects our family and stuff like that. So it's still fairly open, but there's lots of options at the moment for us that we have an idea about. But I think when the time comes, we'll just see where we're at and make that decision. But I think one thing that helped me quite a lot was when I initially was on watch and wait, I was in this mindset of when's the next scan? I want to see how it's progressed. Will that trigger treatment? But what the doctors have sort of explained over time is treatment will be triggered more by your symptoms than by a scan. So it's helped put a lot of control back into my mind, because if I feel good in myself, I know that treatment's probably not around the corner. It's not going to be a scan that says, or most likely, it's not going to be a scan that says you need to start treatment next week. So I found that quite helpful, having a sort of gauge on where I'm at, and it's helped live day to day and just try and make each day good. And that sort of added up to 2 years of not needing treatment since the relapse. So we're just going to carry on like that, I think.
Yeah, I think that's a key lesson, is that none of us know the future, and even with the disease, it doesn't always have the same pace, and it can go up and down, and then you do have the control of when to start. Sometimes it's a medical decision, like, oh, this is bad thing is going to happen to you, but a lot of times it's just, hey, is the treatment going to make me feel better than I do right now? And if I'm doing fine and the disease isn't bothering me, there's no rush to go in, and new things are happening. Philippe, so Andrew's clearly an outlier in his age. Median age of diagnosis, average age is in probably the mid-60s. And so when we take a 75-year-old and say, well, you have a 15-year expected survival, that's not so bad. In Andrew's case, it's a little bit, that's not so attractive. How does age factor into your choice? Or do you have age cutoffs for CAR T or bispecifics? Or how do you approach the age issue and how it affects your choice of treatment or recommendation for treatment?
Not too much, because most of the treatments that we now like to use are less severe than stem cell transplant. And so the eligibility is much broader. And we treat patients with CAR T certainly into their 80s and maybe even a little bit beyond. But that's true for bispecific as well, and other targeted therapies for sure. So I think the age matters because of general health and your ability to tolerate treatments in general, which is of course favorable when you're young. And then in case stem cell transplant becomes a consideration, if research were frozen, which it isn't, but if it were, and you're diagnosed at, you're in with relapsed follicular lymphoma at 28, with the tools that we have, there's a good chance that you might come to a stem cell transplant, especially the kind that you alluded to, the donor transplant. But not until you've really gone through a lot of other therapies. You're right, those other therapies, maybe they'll last you 20 years, but what about beyond there? So, however, having said that, I think research is not frozen. So for sure, there will be better treatment by the time you need them, if you do. And second, there is a thought with CAR T cell that there's still a hope for many of us that maybe a substantial minority, at least, of patients could be cured by CAR T. It's a little bit of a controversial question, and what that number is, we don't know yet, but I think it's possible. So
that raises an interesting question. How do we know how good these treatments are? And CAR T, patients can do well for a number of years after. There's a question in the chat about, or the Q&A about molecular monitoring. So this is sort of a more of a speculative research question, but I know you're your center, as well as others, are working on these sorts of things. Where are we with the molecular monitoring that might replace a scan that will tell us who's got the deepest remission, or is the disease destined to come back? Is that something that's literally on the horizon, or still, pipe dream?
No, it's doable. I think we have the tools. We don't have commercial tools for FL, but we have the tools and the know-how to do that. However, there is no marker of cure, and so even if you have undetectable disease by our most sensitive assay, most patients will still relapse. So these assays are not a test of cure. They test the depth of remission, which is going to be correlated in general with the duration of remission. So they will likely provide prognostic information, but not, it's going to be harder to use them to make treatment decisions. I think there are a lot of hurdles around that, which are probably a little too complicated to discuss on this call. But so in terms of sensitive disease detection by, for example, DNA tests, to be able to influence treatment decision, I think we're not super close, I would say, my guess.
But definitely a goal that people are working towards, so we're not there yet. So a number of questions about, and I addressed this with Andrew a little bit about, what you can do to prevent relapse or delay relapse, and I don't think any of us know, but, I would usually tell a patient all the things we usually tell you to do to stay healthy, right? Good diet, exercise, et cetera, et cetera. So one question is, Andrew, did you do anything specific, start any supplements or vitamins? I'm not recommending them, but, and then the question to Philippe would be, is there anything else you tell patients when they ask you that? Because it's a question we all get. What can I do to keep it away? So Andrew, did you do anything different other than your mental attitude, or?
So definitely, as you say, trying to live as healthy as possible. Before I was diagnosed, I was an 800-meter track athlete, so already sort of had that sort of positive, like healthy living sort of regime in place. So I just tried to a lesser extent carry that on, eating well, exercising. Supplement wise, I did take vitamin D fairly regularly, just to try and I read something to try to keep those levels fairly high. Being in the UK, there's not loads of sun. But no, really like exercise, healthy living, and just trying to keep the body strong, ready for that treatment, because having been through it once, you know how weak your body can become. So from my perspective, want to go into that as strong as possible, because I know the impact it'll have in reducing my strength and like muscle mass, for example. So that's been the sort of way to prep for treatment, if you like. But I think one thing's also important to not be too strict on it. So maybe like 80% of the time, 90% of the time, try to live that way, but not create a stress. So allow yourself to still do the less healthy things as well, and just enjoy life, because I think that reduces stress and has a big impact on how your body operates and feels, and mentally as well. Oh, Mitch, I think you're on mute.
I was Philippe, yeah. Sorry. Yeah, so I was just saying, I don't think I could have stated it any better than you just stated it. So let's see if Philippe has any words of wisdom in addition, but we should take that about,
Right. I agree. No, certainly no greater wisdom could come from me. So
Thank you.
Okay. I think we've covered a lot of the sort of the general things. I'm just trying to think of what else. I don't want to delve too much into the CAR-T bispecific difference, but Philippe, in your experience, having given both, bispecific antibody treatment is moving up earlier, even to frontline, and you guys are pioneering that. CAR-T, not so much, because of the senses, maybe a little more harsh, but do you think there's that much difference? Patients really want to know, like, hey, I've been offered both, or I might be eligible for both. is there anything which would push you for one or the other? Does it matter which order you get them? If you get one and get the other later, what's the sense of the field now, knowing again that it's early and we don't have all the data?
So this is a controversial question, and I think people reply based on typically their own personal interests or research interests, etc. They're both good therapies. I think side by side, if you're just looking at effectiveness, CAR T is probably a more effective therapy than bispecifics given by themselves. And the toxicity is not so different, but it is still higher with CAR T. And there's something about the ease of administration of bispecific, which is attractive for many people. I think that's probably not it's probably not going to remain an important question, because bispecifics are, as you said, are almost certainly moving upstream in the treatment, and probably more so than CAR T. And CAR T is still a very, very expensive therapy, and it's not as easily administered in community settings, etc. So I think that debate probably will be less relevant in the near future.
Great. So there's a number of questions about retreatment, and historically, and I'm going to preempt some of the questions, that if you got bendamustine or R-CHOP, you would get the other one. As you pointed out earlier, Philippe, if you relapse early, you're probably chemotherapy resistant, and then we would switch to something like R-squared, lenalidomide, or now immunotherapy. Does the same hold true for immunotherapy? If you got mosunetuzumab, could you get that again? Would you switch to another one, or would you go to a different, would you do CAR T? Originally bispecifics were given prolonged. Now we're seeing limited time, and maybe 2 years later you relapse. Rituximab, we certainly give over and over. Are we going to see the same thing with the bispecifics?
Possibly. It's a great question. It's a little bit of a research question still. I think there's a lot of interest in this. And likely it will depend, as you say it, as you imagine. Someone who relapses within 3 months of completing is probably not going to get nearly the same benefit from restarting as someone who relapses 5 years later. I'm distracted because I'm looking at all the love for Andrew in the chat, which is really nice. But so I think it is going to be an important question, and I suspect that at least in some cases, it will be possible and advantageous to retreat patients who've done well with these therapies.
Great. CAR T right now is a one-time, probably.
It is. There are patients who have received CAR T twice, and even on the trial like these, the trial of Axicell, which is one of the approved CAR Ts, there was the opportunity for retreatment. So it's a lot to retreat someone with CAR T, I think. But it is similar that you probably can get a benefit for patients who've had a durable benefit the first time. It's not, I don't think anybody would be hugely excited about it, but it's possible.
And one thing that hasn't come up is one drug that's specifically approved in the United States for follicular lymphoma, which is tazemetostat. Most people don't know about that drug. It's really targeted to something we understand about the biology of follicular lymphoma. It's a pill. Durability wasn't as long as we would have hoped, so it's probably used in combination. But any thoughts on that, or are there new forms of that are coming that might change the pattern a bit?
I think you're absolutely right. The results of tazemetostat by itself aren't great, but it's really well tolerated, and the results aren't bad. The average duration of benefit is about a year, but it's so easy. It's so easy to do. Certainly much easier than bispecific or CAR T. And so now the interest, exactly as you said, is in combination. And there's an ongoing trial, like I mentioned, of R-squared plus X, or there's an R-squared plus tazemetostat compared to R-squared, which could definitely be a positive study. And that would be a good way to use tazemetostat. Of course, there are going to be other R-squared plus X, but I suspect R-squared plus tazemetostat is going to be a tolerable regimen. And so for some patients, I think that'll be very attractive. But I hope the drug is not dead. It's an interesting pathway. It's an interesting drug. There are other drugs in development, to answer the second part of your question, that target EZH2 or EZH1 and 2. I don't know that any of them are being developed in follicular lymphoma. They're being developed in some other types of heme and non-heme malignancies. So I'm not sure that there are other trials in FL specifically for EZH inhibitors. The newer drugs are a little bit better in terms of how they target, but I don't know if that'll make much difference.
Great. All right, so I know we're sort of getting towards the last part, and I was just looking through for additional questions. I tried to cover many of them as we were going through, sort of in general terms. As you mentioned, none of us, we're not in a position to give medical advice, and without knowing everything about you, especially lymphoma really has to be personalized in terms of you and your lifestyle and whatever has happened to you. But one of the questions is, we talked a lot about bendamustine starting out, partly because that's a common usage, and also that's what Andrew got. Other people still get R-CHOP. There are limits to how often you can get R-CHOP. Usually you get it for 6 months and you don't get it again in the future. So does that change if someone's had R-CHOP relief? Does that change your opinion, your goal, or you're still going to have the same menu now? It's less limiting because we don't go back to chemotherapy.
Right. The only difference, I think, so it changes if you get transformation, because then you have to use something different. The other thing is chemo for chemo, bendamustine is a little bit more effective than R-CHOP for FL in general. And so if you use R-CHOP and someone and the disease relapses, but there's been some decent mileage, you can use bendamustine. It's a little bit more attractive than the other way around, because if you don't have a great response with bendamustine, the chance of R-CHOP giving a great response is probably less. So that it makes a little bit of difference that way, but not a huge difference overall.
I did want to come back to you, Andrew, with one question. So, bendamustine rituximab, I think, how long did it take you to feel normal after that? And do you have any lingering effects, you think, from that, from the chemotherapy, any long-term effects? Because we've often focused as doctors on the short term. Sometimes we don't worry about long-term. So just how did you feel? How long did it take you to feel normal again, get back to your track activities, and then anything lingering of that?
So I'll start with after each actual round of treatment. I probably had about a week where I was sort of nausea, fatigue, sort of general dizziness, and I wasn't actually physically sick, but really it knocked me down for about a week where I really couldn't do much. So I was having mine every 4 weeks. So after that first week, I started to improve, and then for 3 weeks I would actually feel quite good, and even managed to do some running in between each treatment. So it was a good way for me of trying to overcome the treatment, get back into some exercise, and then go through the cycle again. But that sort of kept me going through each one. But I would definitely say after the last one, the 6th one, it definitely, I think after each one, it knocked me down a bit harder each time. So at the end of the treatment, it definitely took me a bit longer to recover, probably a few months to feel really normal, maybe a month or so to feel a reasonable amount. But then for me, I'd say I've had bits and bobs of sort of fatigue from the treatment, but the main lasting symptom for me has probably been brain fog. So I definitely noticed that my brain doesn't work the same way that it used to. And that's something I've learned to live with, but there is that lasting impact. And I also feel, because I had stage 4 disease in my sort of abdominal area, I don't feel like things have gone back to normal after maybe how much growth there was there. So there is that as well, but my main one was probably the brain fog.
Okay, good. So I'm looking at a couple things there. I just want to comment. Somebody asked about vitamin D and is it helpful? I appreciate you took it. There's a lot of stuff out there. There's no science that says it works in people. There's actually one study that said it didn't benefit people, or people with high vitamin D didn't do as well. Anyway, so there's a lot of conflicting data, but I'm not recommending it. And I don't think Andrew is recommending it. But again, everyone wants to do something, right? You want to feel you're in control. And if you want to be in control, yes, you could take vitamin D or some other vitamin. But, again, it's really everything you would ordinarily do to stay healthy is really the key. Positive attitude, exercise, good diet, sleep, et cetera, et cetera. So I just want to emphasize that we weren't advertising vitamin D on that one. Again, there's a lot of questions in the chat. A lot of them are very specific, and I don't really want to. We can't really go into them. I think we've covered, a fair number of them. We'll go in later and sort of have some follow up on our website, either blogs or written things about some of these. I probably don't want to go here, but there were some questions about maintenance, and that's a whole discussion about, after first line treatment, should you get maintenance rituximab or obinutuzumab? And my 2-second answer to that is it keeps the disease away longer, but doesn't change your overall outcome, and that's a decision you really have to take with your in discussion with your physician as to whether you should get maintenance at all. But I guess the question is, to Philippe, if someone has had 2 years of anti-CD20 antibody maintenance and relapses shortly thereafter, does that carry the same inference as a POD24 after chemotherapy? And the other question was in there, unrelated, is do you count POD24 from the start of treatment or from the end of treatment?
So from the
start, one about POD24 and one is about, does maintenance POD24 have the same impact?
Right. So from the start, ideally, for me. And the POD24, there's nothing magical again about POD24. In general is a very broad statement. In lymphoma anywhere, patients who relapse earlier tend to have high-risk disease. That's true. There's nothing special about 2 years. It's true at 1 year, it's true at 3 years. And it's basically true whatever therapy you use. In follicular lymphoma, it's true even if you just use Rituxan. It's true if you use chemo. So again, I wouldn't be too hung up on the concept.
Okay.
And you're right. So the part about maintenance is very interesting, and also not sure we can do justice to it here as you suggested as well. But you improve duration of remission on average. You don't improve overall survival on average. That means that what happens after the first remission is a little bit less good if you've had it, right? If everything else was exactly the same, then improving the first remission would translate into an improved survival, which it doesn't. And that's actually been, I think there's some suggestion of that. So, and it does affect a little bit how you think about the next line of treatment because of the greater refractoriness to the CD20 monoclonal antibody. Maybe it makes you want to change it if you have Rituxan to use obinutuzumab, et cetera. So it does affect how we think about treatment, and it does play into the overall say course or journey for patients.
Great. All right, so I think in the intro, we're just going to wrap up at this point. There is a third poll on trying to figure out, do you know more about relapse now than you did before? So we're going to ask you that one. Don't know if I'll see that come up, but while I'm waiting for that, I do want to thank, obviously, Philippe and Andrew. This has been spectacular. I think we've gotten great comments, both from the science and the patient aspect, which is really one of the things that we at the FLF really pride ourselves on. I want to thank our sponsors who help get this on, and I think that's on the next slide, which you'll probably see. Yep. So and I really want to thank the audience for their input, their questions, their willingness to put their information out there, and I just, one of the things that always strikes me about this is the heterogeneity of everyone's different experiences, types of treatment, where you are in your journey. So it just points to how heterogeneous this disease is, which makes it unpredictable, but we are making progress on it. From the pole 3 concept, I think everyone, vast majority of people feel a lot better. We now have almost 3/4 of the people ranking at 4 and 5. So I think we've done our job in helping people understand relapse, what it is, and how you approach it. So I'm really pleased to see that. And I just turn it back over to Nick for any final housekeeping details, including our upcoming webinars, which are now up on your screen. Yeah, please feel free to address additional questions in the chat. We will try to collate them and group them and provide some information subsequent to this webinar. It will be available for viewing again, not immediately, but fairly shortly. So if you miss anything and you want to re-listen to parts, you can do that. And if you want to let any of your fellow patients, caregivers, etc., know, they will be able to see it. And please feel free to contact us at these numbers. Andrew and Philippe, any last words? No is okay, but I just didn't want to shut people off. If you have anything you want to say, please, we've got 2 minutes.
No, nothing for me. Just thank you to everyone for joining and the kind words, and thanks for having me.
I'll certainly add my thanks and to both of you and to the audience, but especially to you, Andrew, for doing this and for being so inspiring certainly to me, as well as it sounds like to a lot of people with this disease. So thank you. Good for you.
It's very kind.
Nick, are you coming back on, or that's it?
There's nothing else from my side. Yeah, just thank you to all the speakers, of course, and thank you to everyone for joining. It's been an excellent webinar, and we plan to get the recording up early next week, and we'll continue to communicate on our social channels and via our website as well.
Yeah,
so thanks.
One last thing, which I did forget. I'm sorry. There is a survey out linked through. Can you help me there? Whether it's people access the survey on the website? Can you?
I will share the survey in the chat now.
This is a survey of patient knowledge and interest, and we have a symposium at the American Society of Hematology meeting in San Diego, California in December. It's a huge annual meeting of hematologists and oncologists for blood cancers. And we want to present what patients find of interest, what patients find are unmet needs. And the survey is designed for us to have that and direct the discussion among healthcare providers and doctors at that meeting. So the link will be there, and we would really appreciate it. It's a short, anonymous survey, and the input will really help us shape the field. So we'd be very glad if you would be willing to participate and take a few minutes to fill out that survey. Not right now, doesn't have to be, but in the future, sometime in the next few days, because it's only open till, I think, at the end of the week. So that's my little. And with that, thank you again, Philippe, Andrew. Thank you, all the audience, and we'll see you hopefully at the next webinar.